Good morning, Dr. Brufsky. It's nice to see you again.
Nice to see you too.
So I know we're going to be talking about some exciting updates when it comes to triple negative breast cancer specifically. But maybe we can just start with brief introductions. I'm Karine Tawagi. I'm a medical oncologist at UIC in Chicago.
Okay, I'm Adam Brufsky. I'm a medical oncologist and professor of medicine at the University of Pittsburgh.
Wonderful. So I know you're just coming off the heels of San Antonio Breast. And so we just want to start just with some overall updates in terms of triple negative breast cancer, specifically in the metastatic stage. What are the
Sure.
main challenges that you're seeing in this space?
Well, I think the first thing is let's start backwards a little bit. I think we really have done much, much better in the neoadjuvant therapy of triple negative breast cancer. And I think that, now about 65, 66% of women with triple negative breast cancer will have a pathological response to a keynote 522-like regimen, including pembrolizumab and a bunch of different chemos. And I think that means that there will be fewer and fewer women with relapsed metastatic triple negative breast cancer and more women with de novo triple negative breast cancer that we see. It's very similar, I think, to what's happening or what happened in the HER2 space. And I think that's really great. Given that, though, I think that once you do develop metastatic disease, the vast majority of women will die of their disease within about 2 years, 2 to 3 years. And I think that we need drugs that overcome the various resistance mechanisms that triple negative breast cancers have. The other thing that's kind of a little bit weird is that, triple negative breast cancer is probably about 15, 20% of all breast cancer. And it really is very heterogeneous genomically. And I think that it's kind of like sarcoma. We can never come up with a one size fits all therapy for sarcoma because sarcoma is so diffuse. I think triple negative breast cancer is the same way. Although we're getting there, I think that we're trying to subdivide the breast cancer to various groups and focus treatments on those groups. But despite that, a certain percentage of women, almost all women at some point, will develop resistance, therapeutic resistance, and unfortunately die of their disease. So that's kind of what the big challenge right now is really finding therapies that extend survival. And we have had some in the last couple of years, but we clearly need more.
Yeah, absolutely. I mean, I think, like you said, it's such a heterogeneous population of patients. I mean, have you found that since, the HER2 definition has changed in the last few years, that the population of triple negative has actually maybe decreased a little bit because there are more people that are HER2 expressing than we previously thought?
Yeah, but I mean, we still call them triple negative. We just call them HER2 low,
Right.
and it's unclear whether they have different biology. I mean, I think that what we used to call triple negative was ER negative HER2 2 plus with a negative FISH, and now that patient would be classified as HER2 low triple negative disease, and be eligible obviously for trastuzumab deruxtecan, and that may have changed things a little bit. We'll see. I mean, I think that clearly from Destiny Breast 04, we know that, again, very small group of patients, unfortunately. 60 people were in Destiny Breast 04 that had triple negative breast cancer that was HER2 low, of which I think half of them got TDXD. I mean, there's clear benefits in terms of disease-free and overall survival, but the vast majority of those women still die. I mean, the median the median OS of believe in that group, I believe, and this is second and third line therapy, the median PFS or OS, the median OS was about 18 and a half months. So, we still have a ways to go. And I think that it's interesting. I mean, part of it, to be honest with you, one thing that we're starting to look at a little bit more is how people die in metastatic disease and breast cancer. And it's usually brain mets or liver failure. Those are generally the way people die. And I think once we start to understand that and really get a better idea from autopsy studies of all things, I think there's a lot of autopsy studies that are now circulating in breast cancer where women donate their tissue after they die. I think that gets us kind of an idea, maybe of focusing our therapies a little bit more on, maybe more brain met therapies that we need, or maybe more liver specific therapies where we have stable disease in the liver and extend that for a while. I think, it's a kind of a slightly different way of thinking about it. But again, I think that it's great that we have this new classification because about a third of women now are eligible for trastuzumab deruxtecan that weren't in the past.
Yeah, no, absolutely. And are you seeing a lot of women with triple negative breast cancer still present in visceral crisis when you talk about liver failure?
Not as much. I mean, they do present, some people present with a lot of disease. I mean, the typical woman with triple negative breast cancer who does relapse, which is probably about a third again at this point, maybe, or less, even less now. I mean, now with the Keynote 522 regimen, fewer people are relapsing like that.
Right. It's great.
And so, but when people relapse, a lot of times it's skin metastasis, just, and then suddenly you scan them and they have bone disease everywhere. I mean, when it does develop, when you have early recurrence of triple negative breast cancer, it can be very progressive very quickly in multiple organs. And you can get visceral crisis. I mean, there is the occasional de novo patient that will present to the hospital with cancer of unknown primary, and you realize it's triple negative breast cancer. And they have all the reasons for it. Their strong family history, or they're adopted, and you didn't really know what their family history was. And you'll see that occasionally, but it's not as much. I think again, the real shift has been, and we'll start to see the shift even more now, to less and less, people just blasting through everything and having a visceral crisis. Although we still do see that, but I think it's going to be less and less of that as time goes on.